first thing you should know is what is a partograph. It's very easy. Very, very easy. This is not something I think I need to be going over and over and over again. So as I discussed previously, I said a partograph is a graphical representation of the event in labor. So when a woman is going through a phase of labor, there are three phases of labor, or probably four. We've discussed that before. We're not going to go into that now. But the graphical representations of events that happens during labor is what is called partograph. Is what we use partograph, is what is referred to as partograph. It's graphical representation, the word graph. So partograph. Do you understand, doctors? So, and this
Yeah.
partograph is accepted worldwide. It is standard. It is something once a woman is in labor, the first thing you should be able to do in the hospital is to open a partograph. They will tell you in a teaching hospital here, in labor ward, the first thing, the woman is presenting, she's 4 cm dilated, open a partograph immediately. That's all you should do. So for you to understand partograph, there are different parts of partograph you need to know. This is very important, the part of a partograph. This one you are seeing is just the first page. In the second
Good
page,
afternoon, Dr. Tanya.
actually in the first page, there are other details that should be written. It is not there, but you don't have to go over that one. Depending on the hospital where you are, will determine how the front page will look like. You understand? But this one, what you need to focus for the medical and dental council exam is just this one here. So you need to know the component or the parts of partograph. We won't discuss about the advantage and the other things of partograph. Let's just discuss about the component of partograph. As you can see above here, we have the biodata. The one above here is the biodata. This is the first component. It includes the name of the patient, the gravidity, the parity, the hospital number of patients, the date the patient is admitted, the time of admissions. If when they brought the membrane is ruptured, you want to indicate the time that it was ruptured here. Are you getting me, doctors? These are very important stuff you need to take note of, please. Then the other part is the fetal part. This up here, let me try and see if I can be denoting something here. I believe you can all see my mouse. This part here that I'm circling are all fetal parts. Okay, you can see the fetal heart rate. The World Health Standard is from 160, from 120 to 160. If you can see, there's a thick line here. There's a way we plot the fetal heart rate. We are going to explain how we plot the fetal heart rate. The other component here is the amniotic fluid. There's also a way we also denote the amniotic fluid. We are going to discuss about it. These are the fetal parts. Then the other part is the maternal part. Here, you can see the maternal part. Some people will call it the cervicogram because this has to do with the cervix. Are you getting me? So this is the cervicogram. You can see this is the descent here. Everything about the descent. And this is also the cervix here. Cervical dilatation. How you denote it is indicated in front of it here. I believe I'm making sense. All this is to measure the progress of labor. Are you getting what I'm saying? All this. This is a contraction, which is still part of the maternal part. Are you getting what I'm saying? And if you give any drug during that process, maybe you augment the labor, it is recorded beneath here, oxytocin. If you give any other drug, it is also recorded here. Any drug you give, maybe somebody who is hypertensive, you probably give labetalol. So everything is recorded here. And another important part is the pulse of the patient. The pulse is also recorded here, and the blood pressure is also recorded. We'll discuss how it is recorded. And if the urine, if it is protein, urea, or if there's acetone and the volume is also denoted, and the temperature is also recorded. These are the parts of partograph. Haven't you understand the part of partograph? The next important thing you need to do is, how do you plot this partograph? What do you put in partograph? How do you interpret if you are given a partograph that is already plotted? How do you give your diagnosis? Or how do you plot? So it's better you should be able to plot it, then you can give your diagnosis. So quick one, we are going to go over how you plot your partograph. So in the exam, in certain time in Unilorin, when they did it there, they actually, in one of the stations, they asked them to plot a partograph. So for you to plot a partograph, they will give you a case scenario. Maybe Mrs. Ojuelegba, a 35-year-old gravida, so para, so plus this, so and so. They will give you that case scenario, and they will tell you she's also centimeter dilated as about so time. You just give a case scenario. So you will follow that case scenario and you'll be able to plot the partograph. The question and the clue is you should only start plotting a partograph, or you should only start opening a partograph when the patient is 4 cm dilated. Take note, important key. You only start plotting a partograph when the patient is 4 cm dilated. If the patient is 2 cm dilated, don't start that time. They might want to trick you in the case scenario. They might say, Mrs. Ojuelegba, a 25-year-old gravida, 2 para 1 plus 1, so and so. They might not tell you like, at so time, she was 2 centimeter dilated. You that you don't know, you just go and start plotting. No, at about so and so time, she was 4 centimeter dilated. That is when you start plotting your partograph. So if the patient is not 4 cm dilated, you don't open a partograph. Clue number one. And that is the first thing you start plotting on the partograph. The first thing you start plotting on the partograph is your cervical dilatation. And how do you draw your cervical dilatation? How do you plot it? Your cervical dilatation is, you can see from top here to this top here to down here is your cervix, and it is denoted with X. So when you want to plot your partograph, maybe the woman came at about so time, you record the time, that will be 0 hour. You record the time here. And the woman is, let's say, 5 cm or so 5 cm dilated or 4 cm dilated. You start plotting, you just write your X on this place, 4 cm dilated. At about so time, you record the time here. Please, am I making sense? Please, this is very important. If you don't get it, you should call my attention back, doctors. If you have any questions, call my attention back so I can go over it. So we don't have to be repeating it and people will always say, oh, partograph is the issue. You can be asked to plot a partograph. It's not a big thing that they want you to like. There's no biggie about it. Okay. So that is that about the cervical dilatation. Any question at this point? Any question at this point where I am now before I...
No.
Good, good, good. So, and for the cervical dilatation, you know how to examine. Obviously, in the exam, you won't do all those examination. And cervical dilatation is checked every 4 hours. Are you getting me? The cervical dilatation is examined every 4 hours. That is the duration of time when you check for your cervical dilatation. So every 4 hours, you want to check if the woman is dilated. You want to also you want to record it on the partograph. And if you notice there are two lines here. There's one called the alert line. There's one called the action line. Okay? So normally the partograph should be, when you are plotting your cervical dilatation, it should either be on the partograph or to the left of the partograph. Maybe you are plotting towards this side, it's going like this, it's going like this, it's going like this. It's okay if it's going like that. If it is to the right of the alert line, there's a problem, because the difference is the reason why we have this alert line and action line is if there's a problem with the progress of labor, maybe the descent is the same, is not descending, or the stuff is going towards the action line. You have 4 hours in between to intervene. Probably you are in a home where you need to carry the patient to another place, maybe to your operating table. You have at least enough hours to transport the patient. That's why you have the alert line and the action line. Any question about that, please? And they're about 4 hours apart, the alert line and the action line. Okay? Any question? Okay, good. In the absence of no question, the next thing you need to know is the descent. The descent is also checked every 4 hours. And how do you plot it? You can see 0 here. The clue is already there. The descent is from 5 to your 0. In the case scenario that they will give you, they will explain the descent there. All you just need to do is to come to the level. Maybe it is 5/5. The descent is from 5/5, 4/5, 3/5, 2/5, 1/5, or 0/5, depending on your finger, on the number of the fingers. It's like when you are doing your paviment and you're putting your hand on the below the pelvis symphysis and below and above the pelvis symphysis from the umbilicus down, and you are calculating with your hand how you can feel. Is if it is cephalic presentation, you can say okay, the descent now is also centimeter. You understand? I believe everybody is getting what I'm saying here about the descent. And sometimes sometimes you can put your the during the what's it called when they are checking for the cervical dilatation. They also check for the descent together. When they are checking for the cervical dilatation, please take note. They check for the descent, and also during cervical dilatation, they check for stations. You know how to check for your station. You put your hand, you look for the superior one hand on touching the anterior superior ocular spine. Then you use the other hands to. You don't need this for the exam. You don't need those ones for the exam. All you need is just your descent and you record it. How do you record it? You use 0, something like this. This is how you record your descent, and it is measured every 4 hours. Okay? Any question at this point? If there is no question, can we continue? Any
Yes, we
question?
can.
All right, good. The next thing you need to know is we'll come back to this upper part. Let's just finish with contraction. Okay? So, contraction. What do I mean by contraction? There are three types of contraction you need to take note. The first is a strong contraction, the second is moderate contraction, and the third is weak contraction. What do I mean by a strong contraction? A strong contraction is when when you count for 10 minutes. Actually, contraction is counted within 10 minutes. You place your hand and you count. You use your timer on the what's it called? The gravid uterus. Okay. So when you put your hand, you count. If the contraction is a strong contraction, that means is greater when you are counting the contraction is greater than 45 seconds. Do you understand? When you put your hand, it's greater than, let's say, 45 seconds, thereabout, or greater than 40 seconds. Let's say greater than 40 seconds is a strong contraction. You pray when the woman start contracting and you use your timer. If it is greater than 40 seconds, it's strong contraction. Then the moderate contraction is within 20 to 40 seconds. When it's between 20 to 40 seconds, it's a moderate contraction. If it is less than 20 seconds, it is mild contraction. The trick is how do you plot your contraction? If it is, look at this is contraction column here. Let me bring one column here. Let me bring it here. Or can everybody see what I'm saying? Let's assume these are contraction. These are contraction here. Okay?
Yeah.
Contraction, sorry. Sorry. Let's see, these are contraction. 1, 2, 3, 4, 5. Okay. Let's assume the first contraction is a weak contraction. That means the contraction is less than 20 seconds. Maybe the patient has three weak contraction. So all you just need is just to put dotted line in between here. 3, 1, 2, 3. You see, like maybe this is it here. Three weak contraction. You just put dot in the three this thing because it's three weak contraction. That's how you plot it. That's it. Maybe in about the next 30 minutes, the women has uh 5, let's say, moderate contraction. All you need to do for moderate contraction is just to come here and you just put something like this. Are you seeing what I'm doing? Sorry, this is difficult to do it from here. Can you see, doctors? Can you see what I'm doing? Like you're drawing a slanted line
Yes.
like this. This how you do your what's it called? Your moderate contraction. Then the next thing is your strong contraction. How do you do your strong contraction? If let's say in another 30 minutes, the woman is having, let's say, uh, 2 strong contraction. All you need is you shade it, like you shade that 2 column. Do you understand? That is when I mean 2 contraction, that means the contraction is more than 40 seconds. Do you understand? Each one is more than 40 seconds. The contraction, when the woman starts contracting, it will last more than 40 seconds. That's what is meant by strong contraction. Please, any question regarding contraction? If you don't understand, just let me know right now. Or at this point, any question from since we started to this level, any question? Because I will ask you to plot. I will give assignment to plot Partograph, doctors. If it's better, you just know it.
Doctor, I have a question.
All right, doctor.
For the descent, it's only done when it's when the baby is presenting with the head. Yes, that's the only time you check for descent. That's only when you plot it, right?
Not really. You always check for descent, but for the purpose of this exam, let's forget about the presentation of the child. Do you understand?
Okay.
Let's forget about the presentation of the child, like the presenting part, or maybe the lie. Maybe the
Mhm.
child is bridge, or maybe the child is this. No, let's just forget about it. Because for this exam, all they will give to you, if they will give you a case scenario, will be most likely cephalic presentation. They won't give you bridge.
Okay.
They won't give you bridge presentation. You understand?
Yes.
Child will be presenting cephalic. Do you understand, doctors? Please let take note. In
Yes,
most
doctor.
cases, yes. So any other question? Any other thing? Any question? Somebody is
Please
saying
mute your
something.
mic.
All right. So in the absence of no question, we can continue then. Okay.
Please, I have a question
All right. I'm
for the
listening.
contractions.
Yes.
Okay, for the contractions, if the patient is having like 2 mild contractions under 40 seconds, the lines, do you take 2 parts, like 2 lines?
2 mild contraction under 40 seconds.
Yes.
Okay. So what's the question?
So when you are drawing it on the partograph, do you
Yes.
take the number 1 and number 2, or you go like you're going right 1, 2, 3, or you're going upwards?
You take number 1 and number 2. Like maybe 2 mild contraction will be 1. Like you see the way I'm drawing it, and the second
Yes.
column, just like this.
Okay.
That's how
All right. Okay.
you get. Don't go
Okay.
horizontally, please. Okay?
Okay. All
Yes.
right. Thank you.
You're welcome, doctor. And don't forget, contraction is assessed every 30 minutes. Do you understand? Every 30 minutes. Okay? Any other question? Any other question? As up to this level. Any other question? Okay. So in the absence of no questions, before we continue with this other part of oxytocin, of the drugs you give, the indication, that is augmentations of labor, let's discuss about the fetal part. You know, I told you the other time we have the maternal and the fetal part, the cervicogram and the rest. So what about the fetal part? What is happening at the fetal part? You can see the fetal heart rate. How do you measure, or how do you denote your fetal heart rate on the partograph? This is very, very important. Fetal heart rate is denoted with dot and is recorded every 30 minutes. For example, the first 30 minutes, in most cases, they might be collecting this TOCO in the hospital in practical sense, but in the exam, don't worry, they will give you the values they want you to plot. Okay, these are important values though. So the first thing is, maybe at initial the fetal heart rate was 120. You come to this 120 and you just put a dotted line on it. Then at about the next 30 minutes, the fetal heart rate went to, let's say, 150. You put a dotted line again on it. At about another time, the fetal heart rate is, let's say, 130 again. You put another dotted line. Okay? At about another time, the heart rate went to about 160. You put another dotted line. So after you do this, you now connect this dotted line together. You see, it will be like a line graph. You connect it together. I don't know if I'm making sense, if anybody is understanding all these things. This is very easy. You need to understand it. You understand, doctors? Do you understand the fetal heart rate, please? Do you
Yes.
Yes.
understand what we've just done? The
Yes.
fetal heart rate. Eh?
Yes.
Yes.
Doc, you said it's checked every how many minutes, please?
You said
How many minutes do you
every
Every
check for the
30
30
fetal heart
minutes.
minutes.
rate?
Every 30 minutes. The fetal
Okay,
heart rate
thank
is
you.
assessed every 30 minutes. Do you understand?
Yes.
The fetal heart rate is assessed every 30 minutes. Please take note. Okay. Any other question? Any other question, please? All right. In the absence of no question, then let's continue. Let's continue. So the next thing is the amniotic fluid. If the patient is presented and there's somebody is raising up hand. All right, Dr. Queen B, you wanted to ask a question. I'm listening. Dr. Queen
Yeah, I
B.
wanted to ask a question, but someone else already asked the question. So let's move.
All right, all right. No wala. Let's continue. So the next thing is the fetal, the amniotic fluid. For the amniotic fluid, you want to, if maybe when the patient is presented, there's already ruptured amniotic fluid, you want to record it. Maybe the amniotic fluid is yet to rupture, you want to also record it. So how do you record your amniotic fluid? It's very easy, very, very easy. If it is clear, like it's normal clear amniotic fluid, all you just need to put is just to put C here. Do you understand? If it is clear, you put C. Are you getting me? If it is blood stain, you just put your normal B. It's very easy. Do you understand? If it is blood stain, maybe the amniotic fluid has ruptured and it is blood stain, you just put your normal B. Okay? If the amniotic fluid, if it is intact, maybe it has not broken when the patient comes, you put I, intact. But maybe the amniotic fluid has broken and is stained with meconium. You put what? You put your meconium M. You understand? It's important to understand all these things. They are important. They are diagnostic criteria for some certain event in labor. These are important. For example, when you see a meconium stain and you see fetal bradycardia, it's a pointing sign. There's something wrong with the baby. You understand? So these are important. You need to know how to record. So maybe in the case scenario, they will say the amniotic is meconium stain. You write M at about so time. You record it there. Do you understand how to record the meconium, the amniotic fluid? That is that about amniotic fluid. Then the next part is the molding. Molding. What is molding? Okay. Molding is assessed at every vaginal examination. Once you do your vaginal examination, you want to assess molding, just like when you are checking for your cervical dilatation. So that means molding will be assessed every 4 hours. Okay? And what do I mean by molding? Let me make it easier. Let me go on the whiteboard. Let me try and see if I can draw. Okay? Let's assume this is the fetal. This is the fetal health. Okay. You know, we have your suture now. You have your sutures. You have your sutures. Sorry, my diagram is quite a bit bad. Okay. So when there's molding, when there's what's it called? As the mother is contracting, a pressure on the skull can make this suture to inter like to what's the right English for this? To come together and overlap. Let me use the word overlap. Yes, they can overlap. Okay. And when they overlap, you need to assess it. It's also a very important diagnostic feature. So that makes us to say we have about 4 degrees of molding. We have 0 degree. For 0 degree, you put your hand and you feel the fetal scalp. You can see that the sutures are open. If the sutures are open, it is 0 degree molding. So you write 0. But if the suture opposes or overlap one another, that 0 means there's no molding, no, absent molding. If the suture line is absent, when you put your hand, you can't see the line, you can see suture is not open. That means the skull are touching themselves, they overlap themselves a bit. When they overlap themselves, that means what? There is that is 1st degree molding. 1st degree molding. Okay. Then the 2nd degree molding, they overlap. sorry, for first degree, they are just touching themselves. For second degree, they overlap one another, but can easily be separated. When you just push with your hand, they can easily be separated. That is second degree. But for third degree molding, somebody is saying something. For third degree molding, they overlap and they cannot easily be separated. When you see something like that, it is third degree molding. Please take note. This is very important. Okay? This is very, very important. This is third degree molding. Okay? So that is that about molding. I don't think I need to spend most of my time on molding. So what you do is you also record it every 4 hours, and it is recorded on the what's it called? On the partograph here, where you see molding here. You can see molding. Okay, this is where you record it. So that is it about molding. Another important thing you need to also remember is if maybe a case where you augment the labor, oxytocin, the drug is recorded. Any drug you give is also recorded. Okay? And don't forget also, very important, there are some parameters here. The pulse, it is here, and the blood pressure. When you measure the blood pressure, you also denote it. You come and put an arrow, maybe the blood pressure is, let's say, 120. You come here, put an arrow here, 120 over, let's say, 80. You put another arrow here. That's how you record it. And if it's for the pulse, you use this dotted line. You just put a dotted line on the pulse. Maybe it's 100. The same way you connect the pulse together with the other pulse. Do you understand, doctors? The same way you did for your fetal heart rate. Please, this is very important. This is very easy. Okay, somebody say, please, do we denote the degree of molding with number? Yeah, you know, you denote with numbers. Yes, with numbers. With the numbers 0 plus 1 plus 2 plus 3. Yes, that's what you use. All right, any other question, please? Okay, in the absence of no question, let's continue. So now, let's come with, okay, somebody just type something. Let me see. Say, please do we, okay, still the same thing. All right, so very important thing we need to also know is, how do we give your diagnosis? Because sometimes they might give you already plotted partograph and ask you for diagnosis. Okay, so for already plotted partograph, first thing, when you see a fetal bradycardia, or you see already plotted partograph, you see the fetal heart rate is dropping, first thing, and you see that this thing is either blood stain or meconium stain, what is wrong? Doctor, what is your diagnosis? With that one alone, what do you think is your diagnosis? Let me see people typing in the answer.
Fetal distress.
Okay, somebody said
Fetal
fetal distress. Somebody said fetal distress.
Prolonged,
Somebody saying another thing. Doctor,
prolonged obstructed labor.
What
prolonged
did you say?
obstructed
Will you
labor,
repeat what?
possibly. Okay. Okay, very good. But
What's
for
the question again?
doctor, for this situation, let's go with fetal distress. It could be obstructed labor. Obstruction can cause the fetus to be in distress. But at this situation, you know there is fetal distress because there is fetal bradycardia, or in some cases could also even be fetal tachycardia, plus maybe blood stain or meconium stain. So fetal distress. And what's your line of action to manage that patient, such patient, Dr. Safaya? What is your first line of action to manage such patients?
Cesarean section.
You said what? Cesarean section. Good. You want to section the mother very fast and bring out the child. Good, good. Please, I believe everybody is understanding this whole thing. Any question? Any question? Okay. So, all right. In the absence of no question. So another thing that we should be able to diagnose is obstructed labor is also one thing you should be able to diagnose. Prolonged labor is also another thing you should be able to diagnose. So what are going to be your findings if it is, let's say, obstructed labor? What you will see is the contraction here will be adequate. The woman will be having very strong contraction, even 5 strong contraction. the contraction will be adequate. It can have 2 mild, okay? The contraction will be adequate. But if the contraction is adequate, and one thing you will notice is this descent, when you are checking the descent, it will be on the same level, maybe 3/5, 3/5. It will be the same level. Do you understand? It won't go. Maybe the first one goes, the second one will just be on the same level like this. Do you understand? So when you see something like this, there's arrest of descent, it's not descending, and there is adequate contraction. And sometimes you can check the molding, very important. There might be fetal molding. That means there's something compressing the fetal scalp. The child cannot come out. There's arrest of descent, and there's problem with contraction. So what should you think of, doctors? Eh? Hello, doctors.
Obstructed labor.
Obstructed labor.
Obstructed labor.
Thank you. Obstructed labor. Good. Very good, doctors. And another thing that you can also have, that you can also diagnose here, is also a prolonged labor. So how do you know when a labor is prolonged? First, when you are recording your cervical dilatation, I told you cervical dilatation should either be to the right of the alert, to the left of the alert line, or on the alert line. Hold on, doctors. Sorry, somebody's calling me. Can everybody hear me? Hello? 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 Dr. Abayode, let me call you back. Give me some minute, please. I'm sorry. Yeah, I'll call you back. Yeah. Hello? Doctors, can everybody hear me?
Yes, sir.
Sorry for the
Yes,
break in
ma'am.
transmission. A call came in, that was why. So let's be very quick. For prolonged labor, the cervical dilatation is to the right of the alert line. So when you see cervical dilatation, I believe this thing is still going. The recording is still going. I was trying to record the class for.
Yeah, it's going. It's
Okay.
recorded.
So our time is like 2 or 3 minutes left. So this thing will be moving. The dilatation will be on this side. It will be going towards this side. It will be going to the right of the alert line. When you see a dilatation going towards this side, towards the alert line, first is towards the action line, to the right of the action of the alert line. So it's moving towards the action line. And contraction will be inadequate. That means
Action line.
you might probably be getting mild contraction or weak contraction. Most cases, you might have secondary arrest of labor. So when you see something like this, it is definitely pointing to where? It is pointing to prolonged labor. It's pointing to prolonged labor. Do you understand, doctors? In most cases, they may
So,
want to
doctor,
augment the labor.
the correct.
Eh? Somebody is saying
So,
something.
doctor, the diagnosis of this the criteria for diagnosis of prolonged labor. So,
Yes.
contractions will be inadequate contractions,
Yes.
secondary arrest of labor, and what again?
Cervical dilatation
And
is
what
to the
again?
right of the alert line.
Okay.
You know, this is the alert line. If it's going to the right, it won't be going up. This is going, it's supposed to be going like this. Do you understand? Hello, please let me call you back. Give me some minute. Let me call you back now. Yes, ma'am. Yeah. Yeah. Hello? Can you
We
hear me,
can't hear
everybody?
you. You're breaking.
Hello, can everybody hear me now?
Yeah, please repeat what you just said.
I said for prolonged labor, cervical dilatation is to the right of the alert line. Contraction is inadequate. And the secondary arrest of labor. So in most cases, that is prolonged labor. And this other one